Hi, everybody. This is Professor Mohammed Yassin. I am a senior consultant hematologist, and I am also professor of hematology at Qatar University. Today, I will be discussing with you a very important topic for patients with chronic myeloid leukemia, which is the medical and surgical management of priapism in patients with chronic myeloid leukemia. Over the next few minutes, we are going to touch base on the types of priapism, the pathophysiology of priapism, the treatment of priapism in general, and the treatment of priapism in chronic myeloid leukemia. So how do we define priapism, and what are the different types that we should be aware of? Priapism is defined as a complete or partial penile erection that continues for 4 or more hours beyond sexual stimulation, or that is not associated with sexual stimulation, which adversely affect quality of life, sexual function, and physical wellness. The condition is classified into 3 subtypes: ischemic, or what is described as low flow priapism, non-ischemic, and in another way described as a high flow priapism, and the third type is stuttering or intermittent priapism. Stuttering priapism is characterized by recurrent and intermittent erection, frequently occurring in a specific patient's population, particularly in patients with sickle cell disease, less commonly in patients with thalassemia, and our group recently published paper also describing this kind of priapism in patients with essential thrombocythemia. For a normal erection to occur, the blood flow to the penis should increase, filling the sinuses of the corporal bodies and causing them to expand. This expansion is hindered the tough tunica albuginea surrounding the corporal body, causing compression of the small venules and emissary veins and further raising the pressure inside the penis that is sufficient for penetration. At the cellular level, the most important neurotransmitter is nitric oxide, which is either produced from the endothelial cells or released from NA-NC nerve endings. This nitric oxide through the GC system will reduce the cytoplasmic levels of calcium, causing smooth muscle relaxation. This diagram illustrating the physiology of erection, and you can see in the left side the flaccid status, and just on its right, the erect status. And if you want to catch one thing, you should understand that the normal male sexual function is a complex process which requires an interaction of vascular, neurological, hormonal, and psychological systems. What about the pathophysiology of priapism? What happens exactly? Priapism due to hematological disorder is most likely due to venous obstructions from microemploy thrombi, as well as hyperviscosity due to increased number of circulating leukocytes in mature and immature forms. Other accessory mechanisms are venous congestion of the corpora cavernosa, secondary to mechanical pressure from the abdominal veins, draining the spleen, or infiltrating of the sacral nerve or the central nervous system by the leukemic cells. It is also seen that increased productions of cytokines and adhesions molecules by leukemic cells result in endothelial cell activation and lead to increased sequestrations of the cells in the microenvironment and microvasculature. So briefly, we are describing priapism as erection that is continue, and that is the relaxation will be very difficult, and we have illustrated that we have two types of priapism. If there is under-regulated arterial inflow, this will lead to high flow priapism. And if there is a failure of venous outflow, this will lead to low flow priapism. How can we differentiate further between the two types from the history and physical exam? The low flow priapism is usually painful, it's very painful, while the high flow priapism is less painful, or it can be painless. The duration of low flow priapism is hours to days versus delayed in the high flow priapism. The history of blood disorders, cancer, or injection is characteristic for the low flow priapism, where the high flow is commonly happens with a history of trauma. In the physical exam, characteristically, you will find a hard erection in the low flow priapism versus less rigid or compressible erection in the high flow priapism. And you will find a non-rigid glands and corpus spongiosum when you examine. And in the high flow priapism, you should also examine for location of trauma. What about evaluation? Both types of priapism requiring doing a basic investigations like complete blood count, urea and electrolyte, coagulation profiles. But the blood gas is very differentiating. In the low flow priapism, you will find a pH less than 7.25, and the PCO2 will be more than 60 millimeter mercury, and the partial pressure of oxygen will be less than 30 millimeter mercury. While in high flow priapism, the pH will be 7.4, PCO2 will be less than 40 millimeter mercury, and partial pressure of oxygen will be more than 90 millimeter mercury. With regard to imaging, Doppler and MRI are required for evaluation. So if you combine the history, the physical exam, you do the rapid testing, and you do the ABG, you can easily conclude while you are dealing with low flow priapism or high flow priapism. The timeline of the disease is of paramount importance. And we talk about 3 timelines: 12 hours, 24 hours, and 48 hours. In the first 12 hours, there will be an interstitial edema progressing to destruction of the sinusoidal endothelium. In the next 24 hours, there will be exposure of the basement membrane at the thrombocytes adherence and thrombocyte adherence. In the 48 hours, there will be thrombi in the sinusoidal space and the smooth muscle necrosis with fibroblast-like transformation. So it's very important to treat priapism as an emergency and as early as possible, because it's clearly illustrated here that the timeline is of paramount importance and early, timely intervention is really required. What are the treatment objectives and how many lines of treatment we are talking about? These are the treatment objectives and these are the lines of treatment, and this is just an overview. It's not a detailed treatment. To give you an idea about what you can do as a hematologist or urologist seeing patients with chronic myeloid leukemia presenting with priapism. So at the first line, it's usually initial conservative measures. And we mean by these conservative measures, local anesthesia, aspiration of cavernosal blood, and then cavernosal irrigations. And we irrigate with 0.9% normal cell line. Then you can do intracavernosal therapy with vasoactive agent. The second line treatment is usually surgical therapy, and this complies of shunts and PPI. This is an example of initial conservative measures where you can do exercise, ejaculation, ice packs, cold bath, and cold water enemas. Pansalital reported that cold water enema have been reported to induce detumescence in 6 out of 10 cases. And Atiyah et al. Demonstrated that 24.5% out of 122 patients achieved relaxation from erectile position following priapic episodes lasting for more than 6 hours by cooling of the penis and perineum and walking upstairs. So this is a very important technique which doesn't require money, can be done in any hospital while you are in a low resource or high resource country, and it gives some results and it deserves to be tried. The second line treatment depends on how much time do you give for the first line treatment, indications, or if there is a failure of first line treatment. What are the indications of failure of first line treatment? We're mainly talking about continuing corporal rigidity, acidosis, and anoxia by cavernous blood gas testing, absence of cavernosal artery inflow by vinyl color duplex ultrasound. The second line treatment will compromise of shunts. These shunts can be proximal or distal. If an option for proximal shunt, usually it's an open shunt. If it is a distal, it can be done either subpercutaneous or open shunt. When it comes to chronic myeloid leukemia, we have seen few patients from our patients coming with Priapism, and we decided to have a systematic review and to look at this problem at depth and to see the prevalence, incidence, and the risk factors for developing Priapism in patients with chronic myeloid leukemia, and to determine whether the outcome of patients with chronic myeloid leukemia is simulating the outcome of other hematological disease, and to see if there is a particular difference between Priapism and CML and other kind of hematological malignancy. So hematological disorders are a leading cause of Priapism, accounting for 20% of cases, and this includes mainly sickle cell disease, hyperviscosity syndromes, as seen with a myeloproliferative neoplasm, hypercoagulable status, such as deficiencies of protein C, protein S, antiphospholipid syndromes, and amyloidosis. And we have included chronic myeloid leukemia. So the objective of the review was to assess the characteristic and risk factors of chronic myeloid leukemia patients with Priapism and to realize the common types of Priapism in chronic myeloid leukemia and describe the management options adopted for Priapism in chronic myeloid leukemia, and finally, to investigate the outcome and erectile dysfunction. We thought this topic is of paramount importance, and one of the reasons which give it importance is the age of patients with chronic myeloid leukemia, particularly in the Middle East and Far Asia, is totally different from what is reported by our colleague in the Western community. In the Western community, the median age is around 60 for patients with chronic myeloid leukemia. In the Eastern community, in the Middle East and Far East, there is a different reports. I can tell you that we have reported our experience in adolescent and young adult in more than 300 patients. And the median age for our population was 32. In other countries, it was reported as 38, 42. So having a young population, you expect to have more problems with regard to fertility, Priapism, or sexual issues. So it's worth to touch base on this subject and to illustrate what's going on. So how we acquire the evidence? The acquisition of evidence was done via search in English literature, looking for Google Scholar, PubMed, Scopus of science citations, and indexed databases, including original articles, reviews, case series, case reports, using the terms of chronic myeloid leukemia, chronic myelogenous leukemia, chronic myelocytic leukemia, and Priapism. A total of 68 articles were found and included in our review. Among them, 3 reviews were found from the 3 different contents. The search included cases up to the 4th of August 2020. This is the Prisma flow diagrams, which illustrate our searching and the strategy and how we filtrate our topics. And as you see at the end, we end with 68 articles. So this table is showing the characteristic of priapism and types of priapism which we have identified in this systematic review. So we were able to have up to 102 cases of chronic myeloid leukemia reported with priapism. 32 of these cases were stuttering priapism, while 70 were ischemic. So it's very obvious that ischemic priapism is the predominant type in patients with chronic myeloid leukemia. And as illustrated, the mean age of those patients is quite young. It's almost like 24-year-old versus 28-year-old for stuttering versus ischemic. The platelet count was different between, the mean platelet count was different between the stuttering and the ischemic, around 500 versus 600. And the mean hemoglobin, so most of those patients, they had anemia at presentation, the hemoglobin 9.6 and 8.7. And for stuttering priapism, all patients reporting with stuttering priapism, they were in chronic phase, while in ischemic priapism, we have 1 accelerated phase, 4 plus phase, but the majority were in chronic phase. What about the erectile dysfunction? 16 was not addressed in the stuttering priapism. 13 had erectile dysfunction. 3 has no erectile dysfunction. What about the ischemic group? In the ischemic group, 41 was not addressed whether erectile dysfunction happened or it doesn't happen. 16 had an erectile dysfunction, and 14 no erectile dysfunction. Splenomegaly was existing in 29 patients out of 32 in patients with stuttering priapism, while it was presenting in 51 out of 70 patients with stuttering with ischemic priapism. And hepatomegaly was in 22 in ischemic priapism and 9 in patients with stuttering priapism. So in the era before the introduction of tyrosine kinase inhibitors, the chronic phase of chronic myeloid leukemia accounts for 85% of chronic myeloid leukemia presentations at the time of diagnosis. Most patients were below the age of 40 years with a mean of 27.4 years. This means that this is more common in younger patients with chronic myeloid leukemia. However, priapism was reported also in pediatrics, and there is a few reports, I can cross that, in elderly as well. But commonly it happens in adolescent and young adult. The peak age of priapism in adult without CML is between 20 to 50. Thrombocytosis with a platelet count above 600 is seen up to 30% of chronic myeloid leukemia. What about platelet count and priapism? The high mean platelet count may have some impact on priapism and CML, but it may influence the type of priapism rather than causing it, because we have seen those patients with higher number of platelets, more than 600, they are moving more toward ischemic priapism. While those patients with a platelet count around 500, they are more toward stuttering priapism. In CML patient, stuttering type priapism, the platelet count was lower compared to the ischemic, as just illustrated. Moreover, there is no significant difference in the platelet count between CML patient with and without priapism. In essential thrombocythemia, another form of myeloproliferative neoplasm among the category of Philadelphia negative, extremely high platelet count, priapism was much less reported compared to the chronic myeloid leukemia. The few reports might reflect the minimal role of platelet in including the benign circulation compared to the white blood cell count. Ethnicity might have a role in the predisposition to priapism, as 57% of the chronic myeloid leukemia patients with Priapism were Asian. Most of these reports came from India. This could be due to genetic susceptibility or difficulty accessing healthcare for non-specific symptoms of chronic myeloid leukemia until white blood cell count reached a high level, causing vascular stasis and priapism. Also, priapism occurred in patients with a problem with compliance or stopped their medications. Priapism is a urological emergency. It should be treated early. It is predicted that priapism lasts more than 24 hours. The risk of treatment of permanent erectile dysfunction is more than 90%. Therefore, a rapid and expert reversal of priapism is very much required. The mean time that chronic myeloid leukemia patients with priapism sought medical advice was 78.28 hours, and this was in 76 patients, which carried a high risk for developing a permanent erectile dysfunction. However, the erectile dysfunction after the episodes of priapism in chronic myeloid leukemia patients was reported in 29 out of 102 and did not occur in 17 out of 28. For CML patient, 2 points should be considered. First, the late presentation to the medical attention, which may slow the acting of the medications and less likely to be effective alone. In contrast, urological aspiration, irrigation within the first 48 hours decrease the risk of erectile dysfunction. Therefore, it is reasonable to start with aspiration and irrigation and not to rely on oral medications. Don't depend only on the cytoreductions when you use a high dose of hydroxyurea treatment alone. Get a help from your urologist whenever they are accessible and available. Secondly, treating the underlying medication mechanism of increased white blood cell count is needed to control and prevent priapism recurrence. What about the leukapheresis and priapism? Leukapheresis was used as a modality to treat both the high white blood cell count and CML and priapism. The pitfalls of leukapheresis are that it is not available everywhere, is costly, and may be required several sessions before a significant reduction in white blood cell count, which may take days. Besides, there is no clear cut of white blood cell count value below which priapism is anticipated to be controlled. The mean white blood cell count after which priapism was controlled in our systematic review was 22,000. However, other patients were controlled only with white blood cell count of 3 to 10, remains an option for patients who failed aspiration and refused surgical shunts. In conclusion, priapism is a rare complication of chronic myeloid leukemia. It's mostly seen at the first presentations of the disease and much less during the start of the treatment. It may occur after stopping the medications or post-splenectomy. Late presentation negatively affects the response to the treatment as well as erectile function. Therefore, physicians must intervene early and follow a timely plan and shall follow the patients closely for developing erectile dysfunction. Conservative and medical therapy without urological intervention is less likely to be sufficient. Starting treatment of CML to decrease the high white blood cell count might accelerate the resolution of the priapism and sometimes is needed for complete resolution. At the end of this presentation, I would like to thank those people who supported me to have this presentation and to get it in a timely manner, particularly my colleagues, Dr. Ahmed Al-Majzoub and Dr. Razi, I would like to thank my wife and my family who are always supporting me to get these scientific merits. And I would like to thank my colleague from the National Center at Cancer Care and Research. And a special thanks goes to CML patients and their family who are always motivating us to come with the new solutions and to dig in CML and to come with answers for unanswered questions. And another particular thanks for the International CML Foundation team who are working hardly to get this piece of knowledge disseminated worldwide. Thank you very much.